Hi everybody, welcome to the Education Committee's third video. I am thrilled to say that Dr. Florice Montecillo has agreed to come in and talk to us today about regional blocks. And on Skills Day, we're going to go much more into EROS, and we're going to explain in much more detail. But I just want to point out real quickly before we begin that regional anesthesia is a very important part of the multimodal pain management bundle that we are trying to do. As you've noticed on our patients, they're getting gabapentin pre-op, they're getting ketamine and lidocaine infusions intra-op. We're seeing a lot more use of Exparel. And regional blocks falls into that so that we can minimize opioids as much as possible and get our patients up and moving faster. So that's why I'm really thrilled to say that she's going to come in and talk to us about regional anesthesia and the specifically lower extremity nerve blocks. So you're going to go over adductor canal and popliteal blocks. Okay. Alrighty, so I'm going to hand it over, and we have our little patient here. He's anesthetized right now. He's a sleepy guy. And so first of all, we're going to talk about what to do before the patient arrives in the unit.
Even before the patient arrives in the unit, usually the anesthesiologist calls out to let you know that the block was placed. For pediatric patients, a lot of times the block was placed while they were under anesthesia. For adults, it's usually awake because that was done traditionally, so that with the belief that if the needle came too close to a nerve, if the patient was awake, then you would be more likely to know, and then you would have less chance of nerve complications. However, studies with pediatric patients and having the block placed asleep versus adult patients show that there is actually no difference in safety in terms of nerve nerve damage. But the patient himself might be surprised if it's a pediatric patient, because when he went to sleep, he did not have any stickers, whereas the adult would have had the block placed before he went to sleep and is not going to be surprised with all the stickers there.
Okay.
Yeah, so the other things that we would like before the patient's even there is to make sure that we have the on-cue pump ordered properly, and also that it's available. We've had a lot of shortages lately, and so every day I just call the pharmacy first to let me know, do we have bupivacaine 0.125% or bupivacaine 0.1 available?
Okay. So that's something we would do in the PACU before the patient arrives. We are notified that there will be a local anesthetic that needs to be picked up from the pharmacy and try to get it down before the patient actually comes out.
Okay. Yeah. Okay. All right. So, and then the other thing too that would be helpful is, even though the anesthesiologist should have put in their order what the rate should be for the on-cue pump, it's always good to double check to make sure for pediatric patients that we're at a safe rate. Most adult blocks go at 6 to 8 mils per hour, but for kids who are younger, we want to make sure that that's safe.
Okay.
So, with the assumption, so we were going to use a pen and just do the calculation now.
Okay.
With the assumption that this is always bupivacaine 0.125% concentration, or ropivacaine.
What's the difference?
0.1. They're very similar. Ropivacaine is a derivative of bupivacaine, but the cardiac toxicity of ropivacaine they found was a little bit less likely than bupivacaine.
Okay.
So that's preferred for children, but a lot of times because of the shortage, we use bupivacaine as well. Okay, but they're equivalent to each other in terms of toxic dose. We use the CHOP formula of 0.4 mils per kilo per hour as the maximum safe dose for these two concentrations.
Can you say it one more time? 0.4 mils per kilogram?
0.4 mils per kilo per hour.
Okay. Good to know.
So I just use my calculator. Say a child is 18 kilos, we know that he's coming out with an on-cue pump, and before I even read the order, I would just say 18 kilos times 0.4, and we know that's 7.2 mils per hour would be the max safe dose. So because the on-cue pump only does even 2, 4, 6, 8, and on, I would assume that if I see an order that's higher than 6, I would really be wary, especially because we're sending kids home on this, and the toxicity could accumulate as they're home.
Right. Okay.
Okay. Good. All right. So the next step is we were going to talk about what happens when they first come out. So usually when they're first coming out of anesthesia, we're still doing, without a block or with a block, we're still going to treat them the same. You know, I really appreciate how the PD PACU always has the parents nearby to help, because it's more helpful we find that it's more helpful for pediatric patients to be able to assess pain versus confusion when somebody familiar is there.
They are our best resource, the
Right.
parents, yes.
So, when they first wake up, if they're in a lot of pain, it's regardless of what the block is, it's still safe to treat with the PRN opioids until they're calm enough that we can assess them.
Okay.
So we were going to talk about first with the popliteal, the adductor canal blocks. Okay. So we've got a patient here. The adductor canal block is actually a derivative of the femoral nerve block. The femoral nerve block is here with a very close proximity to the femoral artery. It gives you coverage basically from the front of the knee all the way down here to the side of the leg. So I'm going to use a marker to mark off where it's usually covered. I'm going to go this way. So the femoral nerve block has grown out of favor for the adductor canal block because the femoral nerve block, we most commonly place it for teenagers who are athletes and they had, for example, an ACL reconstruction. What they found was the femoral nerve block, because it blocks the femoral nerve and therefore patellar strength, they ended up getting a lot of quadriceps weakness as a result after the surgery. Like 2 or 3 months after the surgery, they could still see it. So most of the time, instead of a femoral nerve block, they block the femoral nerve at the adductor canal, which is kind of in the mid-thigh, around here. With the mid-thigh, it's they saw that there was less weakness at the in the front of the knee, but still a lot of pain coverage there. So if you have an adductor canal block, you would expect to have coverage basically for most of the front of the knee. And once you get below the knee, it's all
the inner aspect.
Yeah, the inner aspect down to, oh, my marker is not. All the way to the inner aspect down to the medial malleolus.
Okay.
The thing to remember about the adductor canal block is that there's very minimal motor blockage. And the femoral nerve is responsible for almost no motor block below the knee. So toe wiggling should be fine. There should be no foot drop. They should have full motor strength of their foot for the adductor canal block.
So the adductor canal block is mainly for knee surgeries.
That's where we place it most commonly for the knee surgeries.
Okay.
They should not, most of the time for kids who have major fractures, we don't tend to place any nerve block because the surgeon has so much, put so much emphasis on the post-operative nerve exam that we are not usually allowed to do that, and the surgeon might just do local anesthetic before that. But and then the thing about the adductor canal blocks is that a lot of times the child's entire leg is in a wrapping or in a cast or in the brace, and so you aren't actually able to do an ice test on the front of the knee where you would think that the adductor canal would actually be working.
Okay. Do you actually, so because you said ACL reconstruction,
Mm-hmm.
and I know that's the innermost ligament of the joint, so would the adductor canal cover the back of the knee as well? Would it cover the whole knee or just the front?
It covers the front and the inside of the knee, but if there are incisions posterior to the knee
Mm-hmm.
and also very far lateral, you're right, you won't get any coverage for that. And they'll still, even if they have a completely working block, you'll still need opioids.
Breakthrough.
Yeah, so for breakthrough pain for the side of the knee and also the back. Okay. But usually the inside actually does have very good coverage because it's the inside part. The popliteal block / sciatic block is placed posterior, but what you will see, as it runs posterior to the femoral, to the femur.
Mm-hmm.
But what you'll see is usually the sticker coming out of the side. The times that we usually do a popliteal block is a lot of times we've seen our hemonc patients who had really big reconstructions and sometimes resections. So for that, the popliteal block not only provides sensory to the full back of the knee and the lateral aspect of the knee, but also it's responsible for all the motor below the knee. And so if they have a popliteal block, and also the bottom of their sole. So if they've had a popliteal block, yeah, that's where you'll know. Sometimes everyone is different. So sometimes with the adductor canal, you can have the bottom of the foot, just the around the big toe, possibly blocked. But basically everything, most of the everything below the knee is usually blocked by the popliteal sciatic block. Okay. Okay. So moving on to does that sound like a good summary of the two, where it's like the adductor canal is mostly the anterior part and then a little bit of the medial part of your leg, versus the popliteal block being the posterior part and basically everything below the knee, and all motor function should be with the popliteal block.
Okay. It should be intact.
The popliteal block is blocking the motor block.
Blocking the motor. Okay.
So the most common block that we do is the adductor canal block. So there should not be any motor block with the adductor canal.
Okay, good. That's very clear. Okay, thanks.
Okay.
What's next?
So what we were going to do is we were going to talk about the ICE test.
Yes.
Because the ICE test is problematic when the patient has been completely wrapped with their leg, and we aren't able to test the anterior part of the knee. Okay. And so what I find is that doing the ICE test to check the medial malleolus, or just above the medial malleolus, is the most helpful indicator of whether or not the adductor canal block is working at all.
Okay.
Because they can still wake up with pain again from the lateral incisions and posterior incisions.
Okay.
Okay. Yeah. Are you ready, Bobby? Okay. Bobby, hey, we're gonna just check to see how your leg is feeling. Okay. Bobby, can you open your eyes? You could? Okay. So this is just some ice. There's nothing sharp, all right? Does this feel cold?
Yes.
Okay. All right, we're going to check it on your leg, all right? Does this feel cold?
Yes.
Does this feel cold?
Yes.
Does this feel cold?
Yes.
Does this feel cold?
No.
Okay, good. All right, so again, even when there's lots of wrapping, with the adductor canal block, you should still get a little bit of the medial leg with a difference, like a very telltale difference between hot and cold. And we do that instead of testing it to sharp objects, because it's just scarier for kids to have sharper things there and poking them, and we find that it works pretty well. Okay. So we've been working on the assumption that all the blocks have been working well, but we were going to also work on some of the troubleshooting aspects of recovering a patient who's had a block and also had some kind of major surgery.
Okay.
If you suspect that the ICE test is indicative of a block that isn't working, it's always wise to call for help right away, 28963, and just let them know that you've already done the ICE test and you found that the lateral malleolus versus the medial malleolus, there's no difference, so that there's both ICE tests on both sides. Or sometimes the patient might have a good block but still in a lot of pain.
Right.
And it's still helpful to ask them, where is your pain? Sometimes we've been surprised that the pain is actually not necessarily related to the surgical site, but maybe
we do see that.
Right? It's this discomfort from the Foley,
right.
Or they're complaining about positioning injury.
Mm-hmm.
So that's always good to always ask the patient where their pain is. But a lot of times when you call 28963, the charge doc is going to come in with some local anesthetic to give a bolus.
Is that how you test?
Yeah, that's another way to test. If they do the ICE test and it's equivocal, that they're not sure that it's not working, then sometimes it's safe to give a bolus first to see if that can jumpstart the nerve block and to see if it's working. They are still going to disconnect the on-cue pump, but temporarily the bolus is usually a few cc's and then they can reconnect it right away.
Okay.
But one thing to mention notice about the bolus is that we're always going to be looking out for local anesthetic toxicity.
Okay.
The difference between a patient who never had a nerve block versus a patient who does have a nerve block is that in a code situation, in addition to getting the code card, we are still going to also worry about local anesthetic toxicity and the need for intralipid emulsion to save the patient.
Okay. So what are the first things we're going to see in the PACU if we suspect some sort of toxicity situation? And this is when the local anesthetic goes intravascularly, is that right?
Yeah, it could go it could be an undetected intravascular injection.
Okay.
Would be the most likely thing, correct.
Okay.
But sometimes even just the accumulative, if you give a big enough dose and it's been absorbed by the body, you can still have local anesthetic toxicity. Even when you see the doctor, pulling back and there's no blood from the catheter, if the calculations could just be a little bit off, especially for the younger patients, you could still have local anesthetic toxicity even if the catheter was in the right spot. Just
Okay,
giving
so
too much.
what would we see in the recovery room if we suspected this? Would you see, like, I've heard ringing in the ears, numbness around the mouth?
Yeah, right.
What other symptoms?
For
should we be
lidocaine,
looking
you're
for?
right that those are absolutely the first harbingers of problems, the ringing in the ears, the metallic taste in their mouth.
Yes.
And lidocaine rapidly progresses to the most common the most common sign of toxicity is actually seizures, but preceded oftentimes by those symptoms. But for ropivacaine and bupivacaine, unfortunately, sometimes the first sign is cardiac collapse, cardiovascular collapse.
Wow. Okay. So we would immediately.
So you're still going into the
situation, and you would need the lipid rescue card.
Right.
Where's that kept?
So that's always kept in the anesthesia workroom. If you're on the main side, it's going to be in the main side anesthesia workroom. If you're on the SMOB side, there's one on our side as well. And then that's why it's smart to call a code or just call anesthesia now, because we would bring in the PACU, we would be able to bring the code card, but also have somebody who's more familiar with how to administer the local anesthetic lipid emulsion.
Do you need a separate line for that? Would you have to start another line?
Probably not. In a code situation, you would still always. That is wise to always check to make sure that your IV is working before they even give the bolus, because if you're in that situation, you would definitely need at least one IV, but a second IV wouldn't be as important as running ensuring
So you can actually
circulation.
push it through the main maintenance line.
Through an IV.
Okay, just making sure.
Yeah, but that's a great question. How do we prioritize the time? If there's an emergency at the time, we're gonna go to PALS, but also add lipid emulsion to the PALS, pathway.
Okay, sounds good.
Okay, we were also going to talk about the other things besides the most dangerous part of troubleshooting the nerve block is the toxicity, but sometimes other things happen as well. What if the cap falls off? Is it something that do you pull it out and start over? And what I think right now our current hospital policy is that because the risk of infection is so low for these peripheral blocks, and because having a small infection in the skin is not that big of a deal, it's actually been more beneficial to clean the cap. And you can just put alcohol on the cap and call the anesthesiologist, and usually they will replace it. Sometimes cut the wire and re-sterilize it and then put the new cap on, rather than making the patient go through the whole rigmarole of replacing the nerve block. And we've had very minimal problems with. We've had actually no, knock on wood, no infection risks with that.
So can you just explain just a little bit, and I don't know if this is important or not, but where the catheter lands, where you're using ultrasound guided to place the catheter. It's pretty superficial though, right? Is it just barely under the skin, right as close to that nerve as you can get, or is it bathing the nerve? And is position important?
Right, so the position is important because so that's why we're using the ultrasound to make sure that it's in proximity to the nerve.
Okay.
For an adult, usually the catheter is in, the needle, when you actually get into the adductor canal, for example, it's about 6 to 8 centimeters under the skin. Because the needle it's not directly under the skin this way. The needle is usually placed kind of at a diagonal angle. And so the catheter, when you actually see the catheter placed, even though the nerve itself is probably 3 or 4 centimeters from the surface, the actual catheter measurement, if you can see it under the dressing, it's usually 8 to 12 centimeters under the skin.
Okay. Okay, good to know. Just wondering.
Yeah, and then sometimes some people they don't tend to, like when you put the needle in first, and then you're threading the catheter in after the needle, you don't thread the catheter in more than 2 or 3 centimeters past the needle. And so it's not usually too deep, but most people do give themselves a little bit of room to go past where the needle was, just so that the catheter there's a little bit more give when the patient moves, for example, or as they're taking the needle out, that the catheter doesn't go out of the wrong space.
And just one quick question about back to toxicity for a second. Is there a time frame where we should be looking for this? Like if you're in PACU, they're placing the block.
Yeah.
What's the time frame where it's an hour, 30 minutes?
Yeah, anytime within 30 minutes of the placement, you should be looking out for that. That if there's any code situation within 30 minutes, then make sure to always mention that. But honestly, anytime that even an hour later, it's still wise
if it's infusing.
If it's a code team who doesn't know the patient, it's still very important to mention there was local anesthetic given and how much was given at what time.
Okay. All right. Is that everything? I think that's a wrap. Is that everything we can think of? What is your list?
There are a few times that the patient does need a replacement of the nerve block.
Okay.
We have done, depending on the patient, we do a little bit of sedation in the PACU, but for kids who are fairly young and require general anesthesia, it would be good for you to be able to mention, the doc might not realize that the patient is no longer NPO because they've been awake in the PACU, and also double checking the IV. They'll be very grateful that you've checked the IV and made sure that that's also working.
Okay.
It's with each patient, we've had some pediatric patients where we're able to get by on a little bit of sedation and replacing the catheter in the PACU. But generally, this age and below is not going to work so well with sedation, and they're going to need general anesthesia. So, but if the person forgets, it's always helpful to have somebody else mention, well, they just, their mom just gave them some crackers about 30 minutes ago. Like, is this a good time?
Right.
In the chaos of attempting to replace it, sometimes you're the person who might be the
only one that kind of realizes
from aspiration.
Okay. Yeah. Good point. Very good point. Okay, we're done?
Yeah,
all right. So. That was wonderful. Thank you, everybody, for paying such good attention. And we will show this multiple times on our YouTube channel, and we'll also be showing it again on Skills Day. Thanks.
I want to see it!